We all know that pneumonia is a prominent cause of suffering and death with a great clinical aspect. India accounts for 23% of global pneumonia burden with a case fatality rate ranging from 14 to 30%. This shows that India has got high burden of pneumonia, to which there is an introduction of PCV, pneumococcal conjugate vaccine, in the universal immunization program to save the lives, especially children, from this potentially fatal disease. This PCV vaccine in private sector is an expensive vaccine, and now through universal immunization program it is provided free of cost across the country, aiming to bring the pneumonia cases down. I, Dr. K. Kavya, a homeopathic consultant, would like to explain you what actually the pneumonia is. So generally, pneumonia is nothing but there is an accumulation of secretion of the fluid in the alveolar spaces or the alveolar cavity of the lungs. Basically, it is caused by the infection. Or, in the medical terms, pneumonia can be defined as the inflammation with exudative solidification of the lung parenchyma. There are many types of pneumonia. Mainly, the classification is done here. 4 types, that is based on the site, based on etiology, based on mode of acquiring pneumonia, and based on the organisms. Based on the site or the location, it is again of 3 types: lobar pneumonia, interstitial pneumonia, bronchopneumonia. Based on the etiology, it can be primary, secondary, and suppurative pneumonia. Based on mode of acquiring pneumonia, again it is of 4 types: community induced pneumonia, hospital acquired pneumonia or nosocomial pneumonia, healthcare associated pneumonia, pneumonia in immunocompromised host. Based on the organisms, that is viral pneumonia or bacterial pneumonia, parasitic pneumonia or atypical pneumonia. Whatever type may be the pneumonia, pneumonia is always caused through the pathogens, majorly viral or bacterial. Once these pathogens enter into the lungs, we all know that macrophage has got a protective action on the lungs. These macrophages, it engulfs the pathogens. After engulfing, they also trigger and activate the inflammatory cells through the signal molecules or cytokines, that is TNF-A, interleukin 8 and interleukin 1. Once these inflammatory cells, especially the neutrophils, gets activated, these antigens are presented to the T cells. These T cells are also triggered through the signal molecules. Once the T cells gets activated, the cellular defense mechanism and humoral defense mechanisms are triggered. As we know that our body's immune system, once it starts to act, there will be formation of the antibodies against these pathogens. Once the antibodies formations are started, again there is an inflammation of the lung parenchyma. This lung parenchyma makes the capillaries which are present, it starts to leak. So these leaky capillaries, it leads to the exudative congestion. As I said, there is the inflammation of the lung parenchyma, that is the inflammation of the alveolar wall. The air space is filled with the fluid. Here we can see in the picture the air spaces which are supposed to be filled with the air is being filled with the fluid due to the leaky capillaries. In the pathological development of pneumonia, there are 4 stages. The exudative congestion or the stage of congestion is the first stage. This stage is characterized by the grossly heavy and boggy appearing lung tissues due to the inflammation of the lungs, and there is diffuse congestion and the blood vessels are engorged and there is accumulation of the alveolar fluid which is rich in the infective organisms. There are also few RBCs and neutrophils. When the patient is present to us in this stage of pneumonia, on chest examination, we can hear the fine crepitations. After the first stage, within 2 to 3 days, there will be a second stage, that is stage of red hepatization. In this stage, the lung appears red and firm like liver, that is the alveolar fluid is more of RBCs, fibrin and neutrophils are seen. In this stage, grossly the lung appears red and it looks like a liver. That is, hepatitis means looking like a liver. That's why this stage is named as stage of red hepatization. And on examination of the pneumonia patient in this stage, tubular bronchial breathing sounds are heard. After 6 to 8 days of second stage, that is stage of red hepatization, there will be stage of grey hepatization. So in this stage, RBCs are broken down and the red color appears to grey color transformation because of fibrinopurulent exudates. In this exudation, mainly we can see the WBCs, that is more of neutrophils and less of RBCs. On patient's chest examination, we can hear the tubular bronchial breathing sounds. Here the lung appears totally grey, that is the stage of grey hepatization. Once this stage finishes, the fourth stage is stage of resolution. In this stage, the fluid or the exudate is completely absorbed or it is removed by the macrophages and proteolytic enzymes. On examination, we can hear the coarse crepitations on the affected area or the affected lung. Pneumonias can be completely resolved or sometimes it can leave a scar formation on the lungs. When we talk about the clinical features of the pneumonia, there will be sudden onset of shivering or rigors, which is followed by the fever. Patient complains of chest pain and there will be bone pain, body ache, headache, mental confusion. Patient may complain of abdominal pain, vomiting, diarrhea. And when we talk about cough will be productive, as we know that it will be purulent sputum and the sputum can be of green or yellow or bloody mucus, that is hemoptysis. In some cases, the cough can also be dry cough, that is especially in the atypical pneumonia. This atypical pneumonia can be described as a pneumonia which is caused by the agents such as Mycoplasma, Legionella, Coxiella, Chlamydophila, etc. And on examination, that is chest examination, the signs of consolidation can be confirmed when there is a decreased respiratory movements, there is a dull percussion note and marked increased vocal fremitus and vocal resonance, when there is a high pitched tubular bronchial breathing. In the early stages, there will be numerous fine crepitations audible, but in the later stages they become coarse. That is, when we see the patient in the stage of resolution, the coarse crepitations are heard. When we see the patients in the early stages, fine crepitations are heard. Even in some patients, there will be increased heart rate, that is tachycardia, skin can be hot and dry, and central cyanosis, that is bluish skin, and lips or nails can be bluish, but these cyanosis are seen occasionally. If the pneumonias are not treated on time or early on time, then it can lead to the complications like when there is a complete breakdown of the lung tissue and forming the pus filled packets, or the exudations are filled and the pus are formed in the focal areas of the lung leading to the lung abscess, or once the infection is spreading to the pleural spaces and forming the fibrinopurulent exudate, filling these spaces leading to the empyema, and it can also lead to the peritonitis, septicemia, or acute respiratory distress syndrome, pericarditis, endocarditis, meningitis, pneumothorax, or parapneumoeffusions, or it may lead to the respiratory failure, renal failure, circulatory failure, etc. So we all know that in the lungs, the gases are exchanged through the alveolar sacs. So in pneumonia, we know that these alveolar sacs are filled with the fluid. So when these fluid are filled, the proper oxygen and carbon dioxide exchange is not possible. The oxygen is unable to reach the blood streams. So what happens? Usually patient starts to complain, the breathlessness, starts to complain that there is a pain in the chest, mental confusion, arthralgia, myalgia, and so on, because the oxygen is not being properly supplied to the bloodstream. So in the treatment part, we have to always check the airways, breathing, and circulation of the pneumonia patient. And the shock should be treated with the IV fluids initially, and we have to correct the hypoxia, that is the lack of oxygen, with the oxygen inhalation to the patient. And we can treat the pleuritic pains with the medicines, that is homeopathic medicines. Patient presenting with a cough and all other symptomatic complaints can be treated with the homeopathic medicines. And in the investigation part, that is there is a marked neutrophil, there is increased neutrophils, and we can go for blood culture and blood sputum, whether to identify which organism has caused the pneumonia. And on the chest x-ray, here we can see the homogeneous opacity which is localized to that affected lobe or the segment. C-reactive protein will be more than 50 mg. To differentiate viral from the bacterial pneumonia, the C-reactive protein and procalcitonin test are useful. When the pneumonia cases have been severe and it is been complicated, the special tests like urinary antigen testing, bronchial aspirate, and induced sputum test can be done. And in very rare cases, if it is very severe, then fibrinooptic, bronchoscopic aspiration or transthoracic needle aspiration is required. Now, let us know about the different types of pneumonia. So first one, the lobar pneumonia is a very typical example of pneumococcal pneumonia. Here the causative organism is Streptococcus pneumoniae. These organisms causes an inflammatory exudate that involves many contagious alveoli, and segmental boundaries are not preserved, and the bronchi remains patent. These diseases are spread through the droplet infections. Risk factors are children younger than 2 years or people who are older than 65 years, and basically the poverty and overcrowding spaces. Risk factors also includes people who are infected with HIV or severe liver disease, chronic lung disease, or patients having diabetes mellitus, people drinking alcohol, or people with asplenia or hyposplenia, etc. In the lobar pneumonia, the clinical features are similar like all rest of the pneumonias, but the different part is cough will be short, painful, and dry sometimes, and it soon becomes productive. We all know due to the stages of the pneumonia. Here the sputum will be rusty color, that is hemoptysis are seen, but occasionally frankly blood stained. Here the breathing is rapid and shallow, and there is a pleuritic chest pain. As I said, here the tachycardia and central cyanosis are seen. Second one is the interstitial pneumonia. Here we can see that the inflammation is confined to these interstitial spaces of the alveolar. In between the two alveolar sacs, the interalveolar septum which is present, there the inflammation takes place and the pathological process of the pneumonia takes place. Basically it is caused by the organism Mycoplasma pneumoniae. So we can differentiate this pneumonia with the rest of the other only through the X-ray, that is reticular pattern is seen here. Reticular pattern, that is mesh-like or net-like patterns we can see in the chest X-ray. So third one is the bronchopneumonia, that is especially bilateral and patchy. Here the inflammation is restricted to the conducting airways, especially the lower lobes, that is terminal ones, and respiratory bronchioles and surrounding alveoli. It is characterized by the suppurative inflammation which is localized in patches around the bronchi. It can be or may not be localized to single lobe of the lungs. Here on the X-ray, atelectasia may be present, that is collapse of the lungs can be seen here. Okay, collapse of the lungs, we can differentiate it right on the X-rays. Here mainly the causative organisms will be Staphylococcus pneumoniae. Next is the primary pneumonia. Here no any pre-existing abnormalities of respiratory system are seen. Here basically the causative organisms are like Streptococcus pneumoniae, Haemophilus influenza, Staphylococcus aureus, Klebsiella pneumoniae, Streptococcus pyogenes, Pseudomonas, Mycoplasma pneumonia or Actinomyces israelii, etc. So next is the secondary pneumonia. In the secondary pneumonia, there will be some sort of pre-existing abnormalities of the respiratory system are found, and in the sputum test, there will be no any specific pathogenic organisms is been detected, but it can be due to aspiration of pus from infected food, infected nasal sinuses, or aspiration of gastric contents in the patients who is already suffering with gastroesophageal reflux disorder, or there can be inhalation of some septic matters during the tonsillectomy, that is removal of the tonsils, or during dental extractions. The secondary pneumonia can occur. Next one is the suppurative or necrotizing pneumonia. As we know that in most of the pneumonias that can be either primary or secondary, once the microorganisms or pathogens is been removed successfully, there will be complete resolution occurs in the lungs. But sometimes the complete resolution will not occur, that is normal lung structure is not restored. In some cases, at that time what happens, these lung tissues are being destructed again and again, and there is inflammation, lung abscess formation, or subsequent development of fibrosis and bronchiectasis takes place. This condition is known as suppurative or necrotizing pneumonia. Here mainly the causative organisms can be Staphylococcus aureus or Klebsiella pneumonia or Haemophilus influenzae or Staphylococcus pneumoniae. So next one is the pneumonia in immunocompromised host. In the name itself, we can understand that patients whose immunity is completely lacking, or patients who are suffering with chronic major diseases like HIV or malignancies, or patients on immunosuppressiveness, and patients like neutropenic patients. Usually it is caused by atypical organisms like Mycobacterium tuberculosis or Pneumocystis jirovecii. Next one is the community acquired pneumonia. This name itself suggests that people who are staying in that community, that is like people who is not hospitalized or who is living in a long-term care facility like more than 14 or 15 days before getting this pneumonia. This is like having an acute pulmonary infections with a pneumonia, and rest all the clinical features will be same like the pneumonia. Here the main causative organisms can be like Streptococcus pneumoniae, Haemophilus influenza, Moraxella catarrhalis, Legionella, Mycoplasma pneumoniae or Chlamydia pneumonia, etc. So next is the healthcare associated pneumonia. So in this, the infections occurring within 90 days of people who have been in the hospital for the long term hospitalization, or in the nursing home, or in the long term care residences. This healthcare associated pneumonia, it closely resembles with the hospital acquired pneumonia or the nosocomial pneumonia. So next is the hospital acquired pneumonia. So it indicates the development of pneumonia after more than 48 hours of hospitalization. So here majorly the cases can be like it occurs outside the ICU, or the patients who are at high risk cases, and we are treating when the doctors or the nurses or the hospital people when they are treating such cases, or patients who are on the mechanical ventilators, that is ventilator associated pneumonia. Here the causative organism predominantly will be gram negative bacteria like Pseudomonas, E. coli, Klebsiella, Streptococcus aureus. So here the risk factors are like aspiration of oropharyngeal secretions or supine position in the hospitalized patients, and prolonged hospital stay, cigarette smoking, or in the elderly aged people with the uremia or alcoholism, when there is intubation, that is endotracheal intubation, when the patient is malnourished, or in the neutropenic, that is completely immunosuppressed patients. So in the etiology, we can see that pneumonia can be early or late. Early, that is within 4 days. Late, that is after 5 days after the hospitalization. So in this hospital acquired pneumonia also, we can term it as early and late. Early means within 4 days of the hospitalization. Late means after the 5 or 6 days after the hospitalization. In severe cases, that is hospital acquired pneumonia, it can be defined like patient who are having with respiratory failure, if they get respiratory failure, or rapid radiographic progression, multilobular pneumonias, or cavitation of the lung infiltrations are seen. Then there is a evidence of severe sepsis with hypotension or end organ dysfunctions, and shock will be present. Urine output less than 20 ml per hour, or total urine output is less than 80 ml per 4 hours, and acute renal failure, that is requiring dialysis. In all such patients, that is hospital acquired pneumonias, are very commonly seen. So last one is the aspiration pneumonia. We know that this pneumonia occurs if there is anything aspirated. That is the abnormal entry of the fluid or any particular matters. It can be exogenous or endogenous secretions into the lower airways. Here the disposing factors, like when there is a reduced consciousness or dysphagia, that is from the neurological defects, when the patient doesn't know whether he is swallowing or not, then any disorders of upper GI tract, or any other miscellaneous conditions. Sometimes there can be impaired cough reflex, like due to medications or alcohol or stroke or dementia, and sometimes the gastric contents can enter into the lower airways due to its reflex, or sometimes through tube feeding, or when the patient is having impaired consciousness, it might be cause of cardiac arrest or medications, or general anesthesias, or due to alcohol consumptions, or sometimes like neurological diseases like stroke, and impaired swallowing, like as I said, in case of GERD, that is esophageal diseases, or sometime cancer, or chronic obstructive pulmonary diseases, or in cases of seizures or multiple sclerosis, or in Parkinson patients, or sometimes a patient who is on the mechanical ventilation intubations. So this aspiration pneumonia, again, it can be of two types, like chemical aspiration pneumonia and bacterial aspiration pneumonia. In the chemical aspiration pneumonia, it occurs due to the aspiration of the substances that are toxic to the lower airways, but it is independent of bacterial infections. Here the clinical features like fever will be there, dyspnea, that is breathlessness, cyanosis, and diffuse crepitations are heard. On chest X-ray, here as mentioned, we can see that infiltrates involving the dependent pulmonary segments within 2 hours of aspiration. So treatment will be always the tracheal suction to clear the fluids and particulate matter. In the bacterial aspiration, it is caused by the bacteria that normally resides in the upper airways or the stomach. Here the clinical features are like cough, fever, or sputum will be purulent, and dyspnea. Then over a period of several days or weeks, the weight loss and anemia are seen in the chronic patients. So it is also again diagnosed with the sputum, that is sputum discharges which are present in the sputum through the sputum test. And on the X-rays, again dependent pulmonary segments are seen in the upright position, that is lower lobes are affected. If the patient is in the upright and position and the aspiration has taken place and pneumonia sets in, the lower lobes gets affected. If the patient is in the recumbent position and the aspiration pneumonia takes place, then the superior segments of the lower lobes or the posterior segments of the upper lobes are being affected. So here this is how the different types of pneumonias are there, and homeopathy has got a wide scope in the management and in controlling the pneumonia, especially when the patient is presenting with the numerous complaints and symptoms. The homeopathy has got a best approach in it. The homeopathic remedies, like if the a patient is having pneumonia and he approaches to the homeopathic physician in the first stage itself, that is in the stage of exudation, we can think of Aconite, napillus. This is the wonderful medicine. If there is so much of rattling of mucus in the chest and very little expectoration is coming out, we can think of Antium tart. And when there is thirst complaints are much prominent, that is he drinks very often but only little quantity, so much of restlessness and breathlessness is seen, we can think of Arsalp. When there is a burning in the chest also, if Arsalp fails, you can think of Bryonia, as there is cuff is loose and there is sharp sticking pain in the chest, breathlessness is seen. We can also think of Ferrum for 6x in the beginning of the disease itself or in the later stage as well. When there is a bleeding from the lungs, we can repeat this Ferrum for 6x every 2 hours also. Along with the Ferrum phos, even we can give Kalium in alteration with it. It has got very good results when the mucus is thick and white. When the Antium tart and Bryonia fails, we can even think of Phosphorus, which has given a very good result. When patients complains of nausea and wheezing chest, we can think of Ipecac. Even Iodatum 3x is also indicated in every stages you can give in any stage of pneumonia. When the cough is very difficult to come, we can repeat this every hour when the sputum is bloody. Next is the Tuberculinum 1M, that is bronchopneumonia, especially in the children. When there is a dry hacking cough, when the child is sweating profusely and there is loss of weight, and on examination reels are heard all over the chest, you can think of Tuberculinum 1M 1 dose. And in Veratrum viridae, when there is extreme congestion of the chest and when there is oppression of breathing and breathlessness, even nausea and vomiting are seen, we can think of Veratrum viridae. But always remember, the homeopathic medicines are to be given only after the proper consultation with the homeopathic physician. Never ever take homeopathic medicines independently. Hope this video was useful in understanding the pneumonia. Do like, comment and share, and do subscribe to KK Homeo Hub for more such informations. Thank you.